teacher, I've been a coach, I've been a school administrator, but most importantly, I was a counselor. I was a counselor for 12 years. And we train all of those folks here at the William and Mary School of Education. The only thing that we do at William and Mary that I've never done out in the world is be a school psychologist. So this felt like a natural match for me. It felt like the exact right landing space for me. So I have a lot of joy in working here and look forward to the time when we're together. In particular, I'm proud of the work that we do here in counselor education. And as I told you, I held that role for 10 years. I very much identify as a counselor. I care very deeply about this program and about the faculty, especially those that are in the room right now. You all have my great respect and admiration. And I'm genuinely in awe of the program that you're building. We are putting together this just incredible online program that was fully enrolled the semester before we expected, and we've grown together and worked together to meet the challenges of serving you. I wanted to talk a little bit about my transition here to William and Mary, but then talk about some pressing problems in the world right now that we need your help with. So for those of you that haven't been to William and Mary, I strongly recommend a trip to our beautiful campus and to Colonial Williamsburg. For me, the best part of the transition here was a tour that I was given of the Christopher Wren building. So for those of you that are unaware, that is the oldest surviving continuous use building in an institution of higher education in the United States. William and Mary is the second oldest institution in America, only behind Harvard, but the Wren building is the oldest building that is in continuous use. In fact, I am teaching a summer school class, and I taught in that building this summer, so I got to be part of that great transition. But when I took my tour, I learned two things that were very important to me. The first one is that education was a part of the founding of the College of William and Mary. So as you might imagine, there were not a lot of students in the 17th century that were qualified to attend the university. So a grammar school was built, was part of the founding of William and Mary to prepare students for entrance into the college. More importantly, the thing that really inspires me about working at William and Mary is that this institution was founded to serve. It was founded to educate, but it was also founded as a gathering space where the greatest minds come together to deliberate on the challenges of our day in the service of the Commonwealth, of the region, and of our nation. Your choice to attend William and Mary makes you forever a part of that great transition. And we're convening now, much in that tradition, around critical issues facing our world, issues that you will help to inform and to improve as counseling professionals. It is a gross understatement to say that we're gathering tonight in times of extraordinary challenge. The pandemic has interrupted our lives in countless ways. No doubt each one of us has some connection to one of the many who have been sick, hospitalized, or lost during the disease. Our work lives have changed, our lives have changed. We've missed important events, they've been altered. If not for the pandemic, and many of us would be in person right now during this gathering. So we gather at a time where great minds are needed to help solve the mental health crisis that's been exposed during COVID. I did a little bit of research. I can't help but being that sort of, geek PhD professor, but I looked at some information on some recent surveys around mental health, and I wanted to share some statistics with you. The pandemic and the resulting economic recession have negatively affected many people's mental health and created new barriers for people already suffering from mental illness and substance abuse. During the pandemic, 4 in 10 adults in the United States have reported symptoms of anxiety or depressive disorder, a share that's been largely consistent. That is up from 1 in 10 adults who reported that in between the period of January 19 to June 2019. My data came from a Kaiser Family Foundation poll. They study health across the United States in 2020. That same poll found that many adults are reporting specific negative impacts on their mental health and well-being, such as 36% are reporting difficulty sleeping, 32% with eating disorders, 12% increases in alcohol consumption and substance abuse. 12% are reporting worsening chronic conditions due to worry and stress over the coronavirus. Your work as a counseling professional is more important now than ever. Here's some more results from the poll that I found particularly alarming. A larger than average share of young adults, so that's folks who are between the ages of 18 and 24, report symptoms of anxiety and or depressive disorder. That 56% in the poll. That's compared to all adults. Young adults are more likely to report substance abuse, 25% as opposed to 13, suicidal thoughts, 26 as opposed to 11%. Prior to the pandemic, young adults were already at high risk of poor mental health and substance use disorder, though many didn't receive treatment. Job loss is associated with increased depression, anxiety, and distress, and low self-esteem that can result in higher rates of substance abuse disorder and suicide. During the pandemic, adults in households with job loss or lower incomes report higher rates of symptoms of mental illness than those without job or income loss, 53 versus 32%. This one I find particularly troubling. During the pandemic, women with children are more likely to report symptoms of anxiety and or depressive disorder than men with children, 49% to 40%. And that a large part of that is due to the uncertainty of the economic conditions, but also the closing of schools. The pandemic has disproportionately affected the health of communities of color. Non-Hispanic Black adults, 48%, and Hispanic or Latinx adults, 46%, are more likely to report symptoms of anxiety and or depressive disorder than non-white non-Hispanic white adults, 41%. And we already know that these communities have faced challenges accessing mental health care. So it's put a bigger spotlight on that problem. And lastly, many essential workers continue to face a number of challenges, including greater risk of contracting the coronavirus than other workers. Compared to non-essential workers, essential workers are more likely to report symptoms of anxiety, 42 to 30%, starting or increasing substance use, 25 to 11%, and suicidal thoughts, 22 versus 8% during the pandemic. So as we move forward, our challenge will be to confront these issues that have been exposed during a difficult time. And I just want to repeat, these disparities are not new, right? They've just taken on greater urgency as we move forward. The American Psychological Association said something about a year ago that I really think is important. They said that we're actually suffering through two pandemics right now. We're suffering through COVID-19, but the long-term effects of racism and the disparities in service of communities of color, of women, of folks of lower socioeconomic groups have been exacerbated and further exposed during COVID. And it brings on the urgency of our work, of our shared work. At William and Mary, one of the things that really inspired me is our shared values of equity, inclusion, and dignity. And we believe strongly that the work that we do can transform communities. These are our core values. I feel certain that many of you are committed to those values as well. As someone, and I'm talking about me, who has a very strong counseling identity, I applaud your commitment to this profession and to the service of the communities where you reside. And I encourage you to apply what you've learned in this program to give agency to underrepresented communities, to marginalized, to minoritized communities. And so I just wanted to welcome you most warmly this evening, to say that I see you, to let you know how much I appreciate the faculty and appreciate you for the work that you're going to do. I wish you just tremendous success during this time together during residency, as you grow into counselors and as you go out into the world to make the change that we all desire. Yours is a most noble profession, and it makes me just tremendously proud that I share that with you. So I welcome you, and I want to let you know that we're here to support you and help you in anything that we can do. So thanks everybody, and best wishes for the week that you have planned.
Thank you so much for being here. We so appreciate you. All right. So Dr. Harris, is Dr. Todd here yet?
Yes, I see her. Yes.
I'm here.
Welcome.
I wish I was here, Dr. Stretch.
Oh, hello. It's nice to
What
see
a great
you.
opening.
Yes, that was a great opening. Dr. Harris, could you potentially, I'm sorry, I'm putting you on the spot, and introduce Dr. Todd? I could do it off the top of my head, but you know.
I want to make sure I pay respect to her. Let me pull out what she, give me 1 second.
Not the long one, Dr. Harris.
Dr. Harris and I have both had the pleasure of working with Dr. Todd in another setting and find her to be an amazing colleague and peer. And so I think we're very fortunate to have her with us tonight. I will say that. And it's in the residency room, Dr. Harris, if you need it.
You know, I could just do it, Dr. Harris.
While we're pulling that up, I do want to remind all the residency students to please be sure your full name is in your profile name so that we can make sure you get credit for being here. If you're not here for residency, it's okay to leave your partial name. That's totally acceptable. But if you are here as part of your residency requirement, please be sure your full name is in the name so that we can make sure you get credit for being here.
I cannot find the bio in the residency, so I'm just going to say what I know, and I'm going to let Dr. Todd introduce herself. But Dr. Terry Todd, I had the pleasure of working with for a handful of years at another university. She.
Oh, Pam, you got muted. I got muted. You got muted. Sorry.
She is a gem. There you go. So I had the pleasure of working with her at another university. And I remember she came in to speak to some of my students. And her presentation was just so relatable, so creative and clear. And all the students were like, well, how could we have you as a professor? And because, you know, they really wanted to have her, you know, as one of their instructors because, you know, the way that she delivers stuff, she's so knowledgeable, but she's so down to earth. And I know that she has been someone that I felt like I can go to and ask questions and not feel silly asking them. So when I was thinking of, like, you know, when I was talking to the team about who would be a real treat for you all, she was absolutely one of the first names I thought of because I love learning from her. Every time I talk with her, I feel like I learned something new. And I really think that we have something great in store for you all. So Dr. Todd, I'm going to allow yourself to like talk about, give your accolades, share all the wonderful things that, you know, you've done, and go right into it. Because like I said, I want to make sure that the students really have a chance to hear from you tonight.
Thanks so much. And I'm so excited to be here. It just sounds like a phenomenal program. And I'm in Virginia Beach, so I'm close to Williamsburg. So I know about William and Mary, and you guys are just great. And so I am thrilled to be here, very honored. I will say that I've spent a little time with some trauma. So we'll just start there. 25 years working in trauma is what I'm going to start with. I guess I need to share my screen. Let's do that. That'll keep me focused. So, you know, just a little side note. I have a little ADD and I tend to get off task. So if that occurs, feel free to mute me, Dr. Stretch or Dr. Harris. And we'll get through it. All right. So this is what I hope to talk about today. Yeah, if I can stay focused. I also have a whole lot of thoughts about trauma. So this is where I could get all sidetracked. So I'm going to try really hard not to do that. So I'm a survivor of trauma, and that's why I said 25 years in the field. I'm a treatment provider, and I'm also a researcher. So having said that, I need to tell you about my biases, and I do have some. I truly do believe that trauma is the root of all evil and most DSM disorders. So we're going to start with that bias that I have. I also question if it should be in the DSM because I have actually seen trauma be cured, and we'll talk about that a little later. So technically, does it belong there? So we're starting with knowing I have these biases when we look at trauma. I'm trying to keep up with my notes too, because I'm having a technological issue as well. We're all just having one of those nights, right? So the reason that I think trauma is so important, and I'll say that I was trained on the DSM-3, and since that time, I have truly believed that these things about trauma, that it's the root of all evil and most of the DSM disorders. So when we talk about trauma, for me, it's always been very prevalent. But if we think about trauma in society today, we know, I mean, just hearing the dean's intro talking about the pandemic, just the pandemic alone has created some trauma for some people. And we'll talk about that distinction in a little bit. But in general, 80% of the population will experience a trauma in their lifetime, a traumatic experience. So if we think that and believe that, then for counselors and mental health professionals to understand trauma is really important. And I am thrilled because it's not been that long ago that we didn't even consider trauma as being the root problem with a lot of the disorders that we're dealing with in mental health. So I think this trauma-informed movement is huge, and it's the very minimum that we should know going in. So that's my hope today, is that we're going to learn a little bit about this trauma kind of informed talk. And my hope is, my true hope is that I'm going to light a little fire, and you guys are going to get so excited about the trauma work that you're going to go off and not just be trauma informed, but be able to resolve trauma. So that's ultimately my hope for today. Yeah. All right. So if you have any questions, feel free to stop me or interrupt. I will give us time at the end to see if we can answer some questions. So when we think about trauma being defined, got a lot of definitions out there. This is the SAMHSA definition of trauma. And I like the way that they've conceptualized this because they're starting with an event, and then we talk about how the event is experienced, and then the effects of that event and the experience on a person and how we function. So this is it's a good way to think about it in terms of definition. So the way we're going to conceptualize it today is we're going to think about the event. We'll speak about that first. Then I'll talk a little bit about the experience and then the effect that it actually will have on our lives. So I like this as the big picture kind of conceptualization. It's a great way to structure trauma. And if you've ever worked in trauma or experienced trauma, you know that trauma is very fragmented. It's not always nice and structured. There's no clear plan. It's just very fragmented in chunks. So this is a good way to structure a way to think about trauma. So we're going to start with the event. If we go to the CDC definition, it talks a little bit about the event. And I'm going to say right here that one of my counseling pet peeves is when we say something is a crisis or a trauma. And I'm going to say those words. So, I'm going to break my own rules. But it's very confusing because an event is just an event. And it's our perception or our reaction that makes it a crisis or a trauma. So I'm going to keep saying that message to you. So when we look at this definition of events, it talks about horror and helplessness and serious injury and the threat of death or injury. These are important things when we talk about an event. So this is the National Institute of Mental Health's definition and the National Institute of Health. So their definition, talking about just the event, uses words like shocking and scary and dangerous. All right, so these are the events. Keep that in mind, just the event. Now I'm messing with my slides. And then we're going to go a little further into our mental health world, and we're going to look at the DSM definition. And even the DSM separates out the event. Are you guys still with me? And the event is huge, but the event does not make for a trauma. So when we look at criterion A of the DSM, it talks more about the event, and none of these definitions really covers it all, does it? So we need to know and be aware of all the definitions out there, because if we go back and we think about horror and terror and danger, those words aren't really found here, but they are actually a part of that traumatic event in criterion A. So we had the dog earlier with the dean, and now I'm going to have the cats, no matter what we do. All right, when we talk about trauma and events and all kinds of things, we have to talk about ways to classify it too. And so when we're thinking about trauma, this is a way we can break it down. The first part of the list are ways that we typically think about types of trauma. So type 1, type 2, big T, little t, single versus a cumulative event, or chronic or complex trauma. Those are all various types of trauma. And then at the lower part of that list are, oops, I'm sorry, I'm doing it backwards. I also have a little dyslexia when I get stressed. So those would be classifications. And then the types of trauma are the lower half of the list, starting with preverbal. And there can be many, many types. I do want to say that none of these lists are exhaustive. They're just kind of getting you thinking. So the next list, this one comes from the National Institute. Nope, who is this? This is the National Child Traumatic Stress Network. And they have expanded that list of events. So these are types of events that could cause trauma. Does that make sense? So just because we have an event, again, it doesn't mean it's going to necessarily result in a traumatic response, but these are just different types of events. I think they've done a good job here because they've really expanded the list. But again, I don't believe it's all inclusive, because there can be many types under this. So if we talk about types, and I was going to have you put it in the chat box, but we're going to move on just for the sake of time, so we can talk about some of the more fun stuff. But if we talk about community violence as being a type of traumatic event, think of the numbers, and you can put them in the chat box. And if you're putting things in the chat box, I'm going to tell you that I can't keep up with that. So Dr. Harris, feel free to like interrupt me if there's important stuff going on in the chat box.
Will do.
Community violence, we think in terms of that, like think of the types that you just come to mind. So robberies, carjackings, muggings, all of that is community violence. Mass shootings, all community violence. And I could go on with that list. If we think of types of disasters, there are a lot of different types of disasters. And I'm noticing on the news lately that they still don't get that a pandemic is a type of disaster. It's not one that we're used to, and we're also not used to it on this level, but it is a type of disaster. So again, we're just talking about the types of events that may lead to a traumatic experience. All right, so the last thing I want to say, all right, I'm going to say it's the last thing. It's probably not. But when we think about events, I want you to think in terms of exposure and dose too. These are two terms that I took from the critical incident stress management people. And we have to consider exposure and dose when we think about someone experiencing trauma. So exposure has to do with the magnitude of the event, how big it is or how disruptive it was in a person's life. How did they hear about it? Did they hear about it on the news or did they watch it? So all of that has to deal with exposure. And you can imagine that watching something on the news would probably be, we're going to say it, not in all cases, but probably would be less disturbing than if you were actually on scene watching something. So it's just something to consider. When we think about dose, we're thinking about how much, how long did it last? Was it a day? Was it a week? Was it a year and a half of a pandemic? So the dose can also impact how we experience that event. All right, so we're going back to that SAMHSA conceptualization of trauma with our 3 E's, and we've talked a lot about event now, so I'm hoping everybody gets that an event can happen. It just happens, and it may or may not be traumatic. The experience is the next piece we want to talk about, and it's really an important piece. So if you don't pay any attention to anything else, this would be the piece I want you to take away. Perception is huge when it comes to how we experience an event. All right, I'm hoping that makes sense. The way we perceive something can also be impacted by how we have lived life, our previous experiences. So the reality is two people can experience the same exact thing. You know, two of us can have experienced the pandemic. One of us may experience that as traumatic and the other one may not. And it's based on perception. So I'm going to give you an example here. Well, before I do that, I want to talk about the image. So some of us, when you saw the image of this man, saw him looking directly at you. And some of you saw a profile or a side view. When we're dealing with trauma, it's so important to be able to see things from many, many different angles. So don't always take what's sitting in front of you as what really is. And that's why I think this image is so great, because you have to be able to shift that, your own perception, because maybe what the person's presenting with isn't exactly what's happening. The example I want to share with you about that is I had a guy call me one time and he's real angry sounding in the message. And he said, I've been fired by my therapist and she gave me your name and said I should see you. One, I'm questioning the therapist in town who send me like all the really angry, cranky people. It's not very nice, but whatever. So I called him back. And when I called him back, I said, hey, I'm calling you back. He said, I want you to know that I'm really effed up. Only he said the word and he was kind of yelling at me. And so my response was, I'm not going to just go, oh, okay, I'm done. I'm out. My response was, great. I deal with really effed up people. So let's see what we can do. What's going on? So when he came to my office, you could just see the seething anger the guy had. But it's very different in my perception if he's angry at me or if he was angry at the other therapist, or was this just part of the trauma that he was experiencing? So ultimately I asked him, were you angry at the other therapist? Are you angry at me? Because you surely look angry. And he said, no, and backed up and was like, wait, I'm not angry at you. That makes a big difference in treatment. So he did not scare me. And I said, we're going to make some rules here. We're going to sit far enough apart that I can get away. And two, like if I feel like I'm being threatened, because that's very different than him just being angry, isn't it? Then we're going to have that conversation. But right now, I'm not going to see your anger as anything other than a symptom of the trauma. So this is why I'm saying you've got to look at things from a lot of different directions. All right, so we go back to perception and two people perceiving the same event differently. When I was a teenager, we went to the mall one day, me and my friend, and my aunt, who wasn't much older than us, picked us up. And, she hadn't been driving very long, so she wasn't a, fabulous driver. The roads were wet that day, and on the way back, there was a big sharp corner. And when we hit that corner, the car started spinning. I was in the front seat and my friend was in the back seat. And while the car was spinning, I was laughing hysterically. Not like hysterical, like it was a disorder. I was having a good time. Like I seriously was having a good time. My friend, on the other hand, was in the back seat freaking out. And she's screaming, stop the car, stop the car, stop the car. Well, when the car finally stopped, we hit a fire hydrant and it stopped the car. We all got out and I am still laughing, except about the car because I knew we were going to get in trouble. But friend was furious with me because I was laughing. So what we need to look at as we both experienced this is very different experiences. If you asked her, it was a near-death experience. If you asked me, it was nothing short of an amusement park ride. Like I loved it. The difference is our lifestyle. She came from a very rigid, strict alcoholic family, very strict system. Very rigid. I came from a family who, after a hurricane, my dad would load us in the car and we would go pull people out of ditches and we would take trees out of people's yards. And my dad actually took me out in a blizzard and purposely, before I had a driver's license, purposely told me to go 30 miles an hour. I'm going to admit it, 30 miles an hour, and hit the brakes so I could spin the car. And he said, and this is going to teach you how you will not get in trouble when you spin a car. So I'm going to say very different perceptions, and it was based on our experiences. Does that make sense to everybody? So perception is key when it comes to trauma. I cannot reinforce how much perception is key to this. So when I put that image up a few minutes ago with the event scene and it had the blue lights, for some of you, you experienced that differently than other people. This is about perception, and you cannot take one image that doesn't upset some people and believe that it's not going to have a different experience for other people. So notice I didn't leave that image up long, and it's because I knew people were going to experience it differently. So we have to be so careful when we deal with trauma and making sure that we are validating someone's perception of an event and that we're exploring that to an appropriate degree. All right, the next thing I want to say, I'm going to continue on this perception thing because it is so huge, huge. There was a study back in the 1940s, and I'm an art therapist. We didn't mention that. So my master's degree is in art therapy. So I've had this belief for a very long time. Holes in trees, when they're drawn, you draw a tree, if you put a hole in it, it's a trauma mark. Now, a trauma to a kid can be very different to a trauma for an adult. So a kid could have a broken bone, and that could seem traumatic, and to an adult it may not. Again, perception. So don't freak out if you draw holes in your trees, especially if they're on the lower part of the trunk. But that is the truth, and I'll swear to you that there is reality to that. And I can tell you how old you were when the trauma occurred. Back in the 1940s, art therapists were looking at this, and they decided that they were going to do some research on it. It was a great idea. They went to a hospital where they had a number of people with amputations. They believed that amputations would be traumatic. Are you with me? Not all amputations are perceived as traumatic. Imagine if you had gangrene and someone cuts your foot off because you had gangrene, you may see that as saving your life or saving your leg. There was a movie, I don't watch movies, so I only know about the movie, but where the guy was in the canyon and he ended up cutting his arm off, right, to save his life. He may not perceive that loss the same way someone else would. I'm sure you've seen recently, and it's only been like the last few years, where we see a lot of kids on TV and they've had an encounter with a shark attack is how I would perceive it. And they're saying that they survived a shark attack and they don't sound traumatized. Perception is huge. If you perceived you survived a shark attack, you're a superhero. If you perceived that you lost a limb to a shark, that's a very different perception, isn't it? So when they did their study, they did not ask the amputees if they had experienced it as a trauma. So their study did not get the results that they wanted, and they said there's no validity to this. But we didn't know in the 1940s about perception and the impact of perception and its important role in trauma. So that's where I'm going to say, at some point, I'm going to redo that study. And if we ask people if it was a traumatic experience for them, I suspect we'll get a bigger correlation with the holes in the trees. All right, so that's a whole other training and crazy business I get sidetracked on. So if we go back to experience, the experience is, we experience an event as being physically harmful, emotionally harmful, or life-threatening. And it doesn't have to be one, it could be physically and emotionally, it could be all three, it could be emotionally and life-threatening. Any combination of this will more than likely make the experience traumatic. All right, I hope you're following. So we're going to start talking about how we conceptualize that experience a little bit. So after you've had an event that could be traumatic, it usually starts in our heads. And that's where, I got all sidetracked, sorry. So it starts cognitively with your thoughts in your head. And then generally, you're going to feel some kind of way about that. So you experience it then emotionally. And ultimately, what's going to happen is if your perception is that it was traumatic, then it's going to start influencing us physically and behaviorally. So when we start seeing those changes, we're seeing much more that this is entrenching as a trauma. And I hope that makes sense. And ultimately, we'll go back over this with the DSM piece, but when it affects us relationally and spiritually, that's when we can diagnose it as a trauma, PTSD. It's a disorder. All right, I feel like I left something out of that. Oh, I need to put this piece in. So we may not immediately perceive an event as traumatic. I am going to admit that I have a little Freudian bend, and I do believe like the defense mechanisms are huge. So if we talk about denial, and it is one of the very first, I believe it is the first defense mechanism, coping mechanism that we experience in life. So denial, it just didn't happen. That can impact how we perceive or experience a traumatic event. So if you're in a really horrific situation and someone is saying, no, I've got no problem at all, it could be denial's influence. Denial is huge and it's very effective. The problem is that after about 6 months, so between 6 and 18 months, if it's denial, it's going to start to break down. And when the denial breaks down, then we'll start to see the symptoms of traumatic stress. So when we talk qualifiers in a minute, that's one of them, is that it's a delayed onset. And that could be because a person has denial. So don't dismiss it if right after an event, somebody says, I'm good, this is fine, I have no trouble with this. Watch them, because it could show up later. I had a kid, he was in middle school and it was his last year of middle school, and his mom completed suicide over the Christmas holiday. When she completed suicide, kid came back to school after the holiday. He went to class. He was doing exactly what he was supposed to do. Everybody was like, oh, look how great he's coping. And I said, we have to be careful, especially with him, because 6 months after Christmas, when is that? It's summer break. So if he's out of school and he starts experiencing some stress, we won't know. And he's going to go to the high school next year, and they're not going to ask him about the trauma when he's having behavioral or academic problems. Does that make sense? They probably won't know, and they won't be thinking back 6 or 8 months, what has happened in the kid's world. So be careful and always check back. I try to check back if a kid suddenly got a behavior thing happening or academic problems that they didn't have. I'm going to check back 2 years. And in that last 2-year period, I can generally find some kind of event that is contributing at least to the current problem. All right, so denial is huge. And what happens when denial breaks down, especially with teenagers and adults? We tend to go for the substances. And we're seeing that right now happening with the pandemic. People are going for the substances to keep that denial in place. And then all kinds of other trouble will happen. All right, so we talked about the event, we've talked about that experience, and now we need to talk a little bit about the effect, because the effect is really important. So an event occurred, you're perceiving it as physically or emotionally harmful, and now you're experiencing the event as traumatic. Does that make sense? Perception was, this is not good, this is scary, it's harmful. Remember those words in the beginning, it was horrific. Then we're going to say it's going to start to manifest itself in your life. And that's what we need to question, is how are we experiencing that event? How is it showing up? What is it doing to us? And remember that it starts in your head, and then it starts to affect your feelings. And then if it's not resolved, we're going to have physical and behavioral problems. So let's think about my friend in the car accident. So had she not processed that really well, she may have started to experience an emotional thing that goes with the car accident. So let's say she had fear and she started becoming afraid to go out and drive with people. So then that fear changes her. She starts to get stomach aches and she can't go off when her friends are saying, hey, let's go to the mall. She gets gastrointestinal distress. And then that changes her behavior. And she's like, I can't go to the mall anymore. I don't want to go out. I'm not doing well. So are you seeing it starts in her thoughts? Then the fear comes, that's emotionally based. Then we get the gastrointestinal problem, that's physical. That leads to her not wanting to go out. That's the behavioral change. And this is a real simple example. It's way bigger and trickier and fuzzier in real life, but just go with me for a minute. So then behaviorally, she's not going off with her friends. The long-term result of that is we now have changes in relationships. And when we have a change in a relationship or your spiritual beliefs, that equates the disorder. That's the G criterion of the DSM. So it generally trickles down just like that. All right, so along the lines of effect, we can think in terms of these really great words that the DSM gives us. There are intrusion, avoidance, negative mood and cognition symptoms, and arousal symptoms. So this is how it's going to show up in someone's life. We're going to have some of these things going on. So if we look at the B criterion of PTSD and the DSM-5, the B criterion is the intrusive symptoms. These are the ones I'm going to say that are the most disruptive and the most disturbing for people when they experience them. A lot of times you'll hear trauma clients say that they feel crazy. Well, a lot of these intrusive symptoms make you feel a little crazy, for lack of a better word. So when we think about, I want to make a point here about flashbacks. I struggle with how they've written it up in the DSM. So if we think about flashbacks, they never happen like, well, all right, I'm going to take that back. They do happen like in the movies, but that happens less often than we see the other stuff. So in the movies, you know, you see the combat vet and all of a sudden he's reliving combat. He's seeing the guns. He's in the same environment as the trauma. That does happen. That does not happen to everybody. More often we experience some sensory impact from a trauma or some symbolic impact. So you start feeling funny or something's not right. Your heart's racing and you don't know why. That is a type of flashback, although we don't tend to think about that because of the movies. So just know that a flashback can be other than just living it. It can be re-experiencing some aspect of the trauma, not necessarily the reliving of the whole entire trauma. I think that's a really important thing to understand. All right, I have to get myself back on track now. So I got all sidetracked. Okay, so here we're confusing a little bit in my mind, and it's the DSM, so I shouldn't question it, but I do. Dissociation, I do not believe a flashback is a type of dissociation. That's what I'm going to say. When I think of dissociation, I think of it in terms of a coping mechanism, and it's on a continuum. So know that not everybody is, I keep forgetting the names of the new movies. You know, I'm old, so it's Sybil. That's the movie in my day. It's Splinter, Shattered, I don't know, something like that is the newer version. But that would be the far end of that continuum where we're really into distress and disorder. And the other end of the continuum is, if you think about surgeons and a lot of trauma therapists will dissociate to a slight degree so that we can get through hearing the traumatic events or cutting into a person. Though you have to dissociate or you would not be able to do that. That you come back from very easily, right? Like I am finished with a session and then I go, wow, that was a lot to process. But in the moment, I have to kind of not be all in my emotion or I'm going to traumatize the client further. And I can't tell you how many cops and firefighters I hear say that when they've told some distressing thing to a counselor, the counselor got very distressed and it shuts them down. So we don't want to do that. But dissociation is a type of coping mechanism and it's on a continuum. It's a helpful thing and it's disruptive nonetheless, but it is helpful. When you have a flashback, I don't believe a flashback is viewed, I don't think it should be viewed as a coping mechanism. I mean, it is a result of a trauma, but it's not going to help you cope. It's going to usually be more distressing. So this is where I'm going to argue with them a little bit here because I think flashbacks should be in a different category. They should probably be in arousal or intrusive and not so much, well, here is intrusion. All right, so anyway, we're going to argue this a little later. Okay, let me see if I missed my notes. All right, so dissociation. one more thing on it. I want to talk about that flashback piece a little more. I was working disasters and it was Sandy. I always say Sandy Hook. It was not Sandy Hook. So I have to get my head straight. It was Superstorm Sandy. And I was in Toms River, New Jersey. And I don't know, some of you may not even be old enough to remember that one. It wasn't that long ago, but it was a nasty, nasty little verging on a hurricane, but it was a superstorm. Anyways, I was working with a FEMA group and we were in a disaster recovery center. And it was inside of an old, like a strip mall. And one day, one of the workers came to me and said that she was experiencing smelling dead bodies. And I have to tell you, like, I don't work places where there are dead bodies. Like so there were no dead bodies. We were in a building and there were no dead bodies. But she said, I'm smelling them and it's freaking me out. I can't get the job done. So ultimately, she was having a sensory or an olfactory hallucination connected to a previous trauma. She didn't connect it to the trauma. When I started asking her about the strangeness of smelling dead bodies where we were, she said that she had worked Katrina and Rita. And when she was at Katrina, she was housed next to the cadaver tent. And so there was the very pungent smell of dead bodies there. So she was having a flashback while we were in New Jersey, nowhere near where she had been. And the situation was very different. You know, it was very hot during Katrina and, you know, it was awful. And we were in a freezing place. So situation was very different, yet she was still experiencing this traumatic flashback of sorts. So I'll tell you later, towards the end of this, how we got rid of that experience. And she came back and was able to continue working. And she spent her whole time, you know, she didn't have to leave, which she was thinking she was going to have to check out and not finish that deployment. All right, so C criterion. This one I think is the most self-explanatory. I don't need to spend a lot of time on this, but it's the avoidant criterion, where we just don't want to talk about it. We don't want to see people or places or anything that would remind us of that event. Again, this one can be a little hidden because you can avoid stuff and people may or may not know that you're avoiding it. My brother was killed in a car accident 20 years ago, and it was in Virginia Beach. I don't drive by the place where he died. I just don't. That's part of my traumatic experiencing of this trauma. So I don't drive by there. One day we were going somewhere and my dad, I was in the car with him. He was driving. He drove by it. And while he was approaching it, I'm going, "What are you doing? What are you doing? What are you doing?" And he is like, "I am driving." And he did not have the same reaction to that place. And this was probably 10 years after my brother had been dead that we had that occurrence. My dad doesn't experience that trauma the same way I do. So I was avoiding the area and nobody even knew that I was avoiding it. So, you know, avoidance can be a tricky piece. Ask people questions. They will generally tell you. When we get to the D criterion, I think this is a really neat addition to the DSM-5. We did not have this before. So I used to call it really weird stuff when I would talk to clients about it. But now we have clinical words, so this is going to help. When we think about the memory piece, I'm going to say that's Swiss cheese memory. And this is how I relate it to my clients. Feel free to use these words because it makes sense to them. When I say Swiss cheese memory, they're just these big gaping holes. And they're like, yes, like I can't fill in that blank. I will say, like, if we were talking a whole lot of treatment, that memory can come back. It's unbelievable how you can fill in the gaps once you use a really phenomenal treatment that can resolve trauma. You can fill in those gaps a lot of times. So unless the brain cells are burned up, and that can be from medication, like speed can burn them up, other drugs can burn them up, head injuries can burn them up. Other than that, your memories are probably still there. We just have lost the link, kind of like a computer. You know, when it crashes, the information's still there. It's just the access to that information is broken. So think of it in terms of that. This persistent and exaggerated reactions to things. Everything's bad. Like I call that Chicken Little effect. And it's like the world's ending. They catastrophize. Everything is just horrible, horrible. And people will understand when you say, oh, Chicken Little effect. I mean, they totally get these words. And so I don't have to go Clinese on them. It works out really well. One of my others is that negative bubble that sometimes you see people in, and that's that persistent negative emotion. Like everything you say, oh, it's a great day outside. And they're like, yeah, but you'll probably get sunburnt. Like, you know these people. And then the last one is the people that I tend to call Eeyore, and they really cannot experience. Do you remember Eeyore from Winnie the Pooh? Just can't experience joy. So, I've had these things around a really long time, but the DSM cleaned up my language and made it nice and clinical. And so I really appreciate this because I see many, many of these negative mood and cognition symptoms. Okay, so now we're going to talk the E criterion, and that's arousal. And these are very disruptive. I would say arousal and the intrusive symptoms are probably the worst, but these are the ones we see as irritable and, angry. And so that guy who came into my office, he was experiencing a criterion E arousal symptom with that anger. And had I just said, no way, I'm not going to deal with you, it wouldn't have gone well. He wouldn't have gotten any help. But by knowing that this is just a piece of the PTSD, you got to look at that whole big picture. And these are the ones you're most likely to see in clients' report. They say I have trouble concentrating, and they say I can't sleep. So these are, I think, more likely to be reported than some of the others. All right, these are some of the qualifiers and specifiers. Again, not going to spend a whole lot of time on this. You've got a psychopathology course, I have no doubt. The depersonalization and derealization, in my over 25 years in the field, I had not ever diagnosed depersonalization and derealization as a disorder. And recently I'm starting to see a number of teenagers showing up meeting this criteria. So I'm starting to even check some of my older clients, but it does seem to be the teenagers and the young 20s. And it's real interesting because I'm actually getting referrals now where they've had that diagnosis. Just another piece of that trauma stuff. And this would be the delayed onset that I said can sometimes be the result of denial. So we always want to check that. In an assessment, these are important questions to ask because we want to make sure we don't miss it and treat something else. And I'm going to mention that, I think, in just a second. But just checking back a couple years from where this disruption that brought them into treatment is occurring. Yeah, so this is where I'm going to talk about a little bit about misdiagnosis and underdiagnosis. I think that we are getting better. 10, 15 years ago, we were not as good as we are now, and we can be even better. And I think trauma-informed assessments are going to make this difference. But misdiagnosis, let's talk bipolar for just a minute. This is one of the things in adults I see most often misdiagnosed, to the point where we have now got it. I think it's in the DSM-5. It could be coming, I don't remember, but that rapid cycling bipolar, it makes me crazy because I'm going to say you should be looking at trauma and not rapid cycling bipolar. So if a person this is life or coasting along, and when you experience something that triggers the trauma, so it goes boom, you spike up. And we get all worked up. So the arousal symptoms, adrenaline starts surging. And when the adrenaline is surging, you're all up here going, ah, whatever. So think about that. This is so true. And it happens with our combat vets. When we use up all of our adrenaline, our body will convert serotonin to adrenaline. Isn't that cool? It's really cool that we can do that. But the reality is when you're up here and then we start using up all of your serotonin along with your adrenaline, guess what happens? You crash and then you look depressed because we've used up all your serotonin. So I'm going to say rapid cycling. I don't know. I would do a lot of research and treatment. And this is the way I do treatment is I treat your trauma. If the bipolar doesn't go away, then it's bipolar. If I treat your trauma and the bipolar goes away, then it was trauma. There is no harm in helping somebody with that and figuring it out. I'm going to say meds are an issue. I'm not going to play with meds because that's not in our scope of practice. But if you can find a psychiatrist to work with you to figure that out, it's huge. The other piece to that is being an art therapist and looking at somebody's artwork. I can slam tell you the difference between bipolar and trauma. They look very different in the art. I can see the difference between anxiety and ADHD. So, you know, have an art therapist who can look at stuff for you and go, oh yeah, that's definitely psychosis, or it's not. But this is where some of the confusion and misdiagnosis and underdiagnosis comes from. Underdiagnosis, I'm going to say it comes from us stopping, or I see it a lot with PCPs. So someone comes in, they say they have a sleep disturbance, an eat disturbance, and bam, automatically you're diagnosed with depression. But guess what? Those are also symptoms of trauma. So we have to continue asking the questions. If you don't ask the question, have you experienced something that you would consider as traumatic or horrific or dangerous, then you're not doing a thorough assessment, and that can easily lead to misdiagnosis. My favorite thing is the Abilify. Now they have a new one, but it used to be Abilify 10 years ago. And they would say 2 out of 3 people being treated for clinical depression with meds are still experiencing symptoms. So you should try Abilify to fix it. Okay, so we're just adding a med on top of a med, when in reality, if we do a better diagnosis and it's trauma, because those meds aren't going to help resolve your trauma, that just makes me crazy. All right, but I'm not gonna have a tangent. I'm reeling it in. Bring it back in. All right, then there are the confounding variables, which I just mentioned, that whole thing with symptoms overlapping. So we have to ask the right questions. If they say, no, I haven't had anything, then it could be clinical depression, and then you should go with that. But if you don't ask the question, that's where we get stuck. Okay. So we're going to talk about my conceptualization of trauma. And I get in a little bit of trouble with this with different groups that I'm associated to. The neuro people do not like when I say your brain's like a computer, but that's how I want you to think about it just for right now. If your brain is like a computer, all right, well, let's back up for a minute. This is, we all know this and would agree. The right side of your brain is, it's the creative side, it's the fun side, it's the loose and goofy side. And then the left side is the logical side. So we know this going in. So now if we think of your brain as a computer, trauma is not perceived in your brain. Okay, so what makes it a trauma is it's something sensory and symbolic. Think about the lady who had the smell. So if you said to her prior to our conversation, did she have trauma from any of her disaster work at Katrina, she probably would have said no. But the fact that she had a symptom that was sensory, that was not processed, made it a trauma. So when things are not able to be processed, all right, so let's back up a little more. Brain's like a computer. When you're sleeping, and we get to that cycle of REM sleep and your eyes are moving back and forth, you're filing events away from the day. So tonight, when you go to sleep, probably your brain's going to have a file for this. It'll be like, yeah, another residency I had to attend, or some crazy lady was talking to us about trauma. Whatever it is, you're going to have a file on the left side of your brain where that information goes. Because traumatic experiences are sensory and symbolic, the left side can't process. So when you go to sleep at night, you're filing all the events away from the day. And then you get to this event that doesn't make sense. I'm smelling dead bodies. What is that? That should not happen. That should never, ever happen. So it doesn't make sense. It gets stuck in the recycling bin. Then the next night you go to sleep, we do it again. It gets to that event and it's like, whoa, I don't have a file for that stuff. It goes back in the recycling bin. One thing may not mess you up too much. Over the course of a lifetime, your recycling bin gets full. Think about your computer. What happens? If your recycling bin's all full and jacked up, it's gonna slow the system down. The system will probably still work, but it slows it down. It can't process as quickly. So that's little t traumas. If it's a big T trauma, that could be an icon on the desktop. So think about that. When something bumps into that icon, the window opens up, right? And then you're kind of reliving some part of that experience. So that's exactly what happened to the FEMA worker. Is she was sitting in that place. She had a sensory experience that hit the icon on the desktop, and she was reliving Katrina, but she couldn't put her hand on it because it wasn't like she was visually reliving it. It was just a sensory experience she was reliving. Does that all make sense? What we want to do in trauma treatment that will resolve traumas is we figure out what it is over here, the sensory and symbolic stuff. What does that mean? We make sense of that, and then we move it to the left side, and the left side goes, oh yeah, I got a file for that. So I told you guys, you know, I'm a trauma survivor. I'm not going to say the ugly words, but in my treatment of my trauma using EMDR, I now have a file on the left side of my head called Really Effed Up S. It's a great file. Once it's on the left side of my brain, when I have any other crisis, guess what happens? In 30 seconds, your body and your brain work together. It surges chemicals up, and it sends us into, I'm not going to have the whole crisis lecture, but it makes your pupils dilate so you can see more. Your brain's processing quicker so it can take in more information. Your heart rate increases so that we can move faster. It's just the coolest stuff happening. But during that 30 seconds, your brain's also going through all the files on the left side and saying, what resources do I have? So guess what? When I've processed my trauma, it's now in the left side in a file. It is an amazing resource. So if we're able to process the trauma correctly and file it, it can be not only not keeping your foot nailed to the floor, but it's a resource and an asset to you. It's amazing. So the other piece is that if you don't resolve your trauma, if you've got stuff in the recycling bin, it kind of nails your foot to the floor. And ultimately, if your foot's nailed to the floor, you can move forward and you can progress, but your leg's going to get all stretched out, and it's not going to work as well as if you got the nail out of your foot and you could move forward. I hope that makes sense. All right, so we're going to talk a little more about conceptualization, and then I'm going to give you all some time to ask some questions. I hope it'll happen. All right. So again, I told you that these are all the domains that we're experiencing trauma in. It generally starts in your head with your thoughts. It's cognitive. And then how we perceive that is going to dictate. I argued with a psychologist about this, George Everly. Like, I argued because I was like, no, as an art therapist, I'm like, everything happens in your feelings. It's all about the feelings. It has nothing to do with the thoughts. Over time, I was convinced, and I absolutely believe that it starts in your thoughts, and they impact how you feel about something. So an event happens, you have a car accident, and you start to be fearful. That's the emotion. And then that fearful, remember how it goes, starts to have a physical impact. Maybe you have anxiety that goes with the fear. And then the anxiety makes you such a wad that you can't leave the house. So it's having a physical impact. And then because you can't leave the house and go do the things that you used to do and socialize, then it's affecting your behaviors. And ultimately that will impact your relationships, and your spirituality could be impacted. When those bottom two, relational and spiritual, have been affected, that's the G criterion, and that makes it a disorder. I do want to mention that there are a whole lot of people, many of you are running around with cognitive, emotional, potentially physical and behavioral issues that are the result of trauma, and you're going to school and you're keeping full-time jobs and you have families and you're functioning fairly normal. That's post-traumatic stress. And I want to make a real point that many of us are running around with post-traumatic stress, and it's not really messing our lives up. It could mess us up if you drive by a place, or if something else that you have used to maintain these symptoms or to keep them at bay falls apart. I saw that happen a lot to people in the pandemic. So the people who travel as their coping mechanism, boom, suddenly you can't travel. And now we've got stuff coming up. Think about it in those terms. Yeah, sorry, I got distracted by a stupid text message. You should always cut the phones off when you're doing stuff. All right, so if it's still in those 4 domains, you can still be functioning. I also believe that if you treat it while it's in the top 2, if you've got cognitive, emotional trauma and we treat it right there, it will not turn into physical and behavioral stuff if you treat it correctly. Once you have the physical and behavioral, it's a little more entrenched and it's a little trickier, but If you resolve it there, then it probably will not impact your relationships or change your spirituality. So it's mitigating. If we treat it early on before it turns into the disorder, we may be able to, and hear me clearly say, may be able to mitigate the trauma. And it's a little different. I do want to back up and say it's a little different with complex trauma and cumulative trauma. Sometimes, especially for children, chronic trauma can change chemicals. So you could legitimately be bipolar caused by a chemical imbalance. Again, I'm going to say rooted in trauma, but it can actually change your chemical makeup, and then you will need meds. I'm very anti-meds, but I will be very honest in saying that sometimes if our chemical makeup is changed and we can't reset that, can't recalibrate, then you're going to have to use medication. The people who need meds generally tolerate them relatively well. The people who don't need meds, sometimes that's where we have trouble. And then with my clients, I will also help them understand that the meds all act different. So we need a really great psychiatrist to help work through what is the right med. All right, so I'm not totally bashing meds tonight. Okay. Take a deep breath. Man, I was going fast. Sorry. I hope that it was all making sense. But when we work with trauma, these are some of the things that I feel like personally are really important if we're going to deal with people and their trauma. So first, I have seen landmine things happen when we have a counselor who has not dealt with their own trauma, and they will link up. And you talk about transference and countertransference type nightmares. It can be very, very bad. So if you haven't worked on your own stuff, have a really good list of referrals. You know, like you can do all the great CBD, that wasn't good. CBT, I had a client yesterday messing with me with that. So CBT techniques, which we'll talk about in a minute, that will actually help cope and manage, but they're not going to resolve trauma. And I want to be real clear that trauma can be resolved, but we always have to do that frontline stuff. So just know where you can go. If you have not worked on your own, if you're going to be triggered, it's best that you not treat trauma clients. Crisis intervention is huge. I think it's important for all counselors, just my own, another bias that I have. But clients don't generally show up when they're feeling good. I have not experienced that in my career, that they come in and they go, yeah, I'm really great. And let's just do some work. Not happening. Usually some kind of crisis experience has happened and then they show up at your office. So having some really great crisis intervention skills, I think, is huge and important. I'm going to say that I think the cops and the firefighters have the best crisis intervention training. It's critical incident stress management. I just think it's a phenomenal tool to have. And if you're going to deal with trauma, it's a great place to start because it'll give you a structure. In crisis intervention, and this is a lot of times when our trauma patients are exploding or they're having some kind of reaction, it's really important to do the crisis intervention because that's containing. So if you think about it this way, crisis intervention is putting somebody back together and containing it, when in a lot of times in treatment and therapy, what we want to do is open them up. So having those crisis intervention skills when we do treat trauma is huge because we're going to go in and open them up, but we want to be able to close them back up. You don't want to send them back into the world a mess. They're not going to come back. So if we're able to close them back up and send them back to their families, and then they come back the next week, you open them up again, we do the work, we close them back up. That's a better way to go. And it's crisis intervention skills that will help you do that. You don't ever want to pathologize. A lot of times people who have a traumatic event will say, oh, and now I'm going to be psychotic, or now I'm going to be bipolar, or whatever it is. Like back up and say, let's do some assessments. Let's look at this and let's see, because it's not necessarily a horrible. I will say, if we have to have a trauma diagnosis, it's the best diagnosis we can give someone because there are actually ways to resolve it. It's a good thing. Oh, we just had some close lightning. So if I lose you, it'll just be the storm that we're having right now. Let's go on with the rest of the day. Okay, training is really, really important. So I have not seen it as much now, but back in the day when I was more in the field, a lot of people were saying, yeah, I treat trauma. They'd read a book or an article or two. Don't do that. Training is really, really important. So go get some very specific trauma training. There's a great place to start. Bessel van der Kolk's book is huge. The Body Keeps Score. That, I would say, that's the best place to start on your trauma learning journey. And then people who have experienced trauma feel crazy. So a lot of times they don't want to talk about it. So us kind of taking that away from them. And I say that right off. It's like most people who have experienced some kind of traumatic event tend to feel crazy. And they're like, oh my gosh, I so feel crazy. And they feel like everyone's looking at them. If you can take some of that away from them and normalize it, it's amazing what that'll do in getting them to come back. All right. So this next statement, the trauma treatment should never, ever be worse than the trauma itself. I saw a guy on TV, a psychiatrist, it was a lot of years back, 10 years back, and it was Dr. Abloh. I'm going to sell him out right now. So Dr. Abloh said to a combat vet that going through the trauma treatment work was going to be significantly worse than the original trauma. And I was like, that should never, ever, never happen. Hear me loud and clear. That should never, ever, never happen. If you have good crisis intervention skills and you're watching your client, you can see when they're getting distressed or they escalate to a point that we need to pause. And I do that with my clients. They're telling the story and they're getting really, really worked up. It's like, let's take a pause. Let's take a time out. Let's work some of your coping skills that you've learned through the CBT training that we did prior to digging up your trauma. And then they realize that they can control it. So that's a twofold thing happening there. You're teaching them that they can manage the symptoms, but you're also keeping them in the room with you. Who wants to go in and have a horrible experience trying to work through a trauma? So watching that very carefully in the process of being able to open someone up and access it, and then being able to close them back up is really, really huge in trauma treatment. It should never be worse than the original trauma because they didn't have any control in the original trauma, but they have all the control of how we do the treatment. All right, I hope that that makes sense. And I can't see that last block. Oh yeah, and trauma can be resolved, like not just treated, resolved. Okay, my computer's goofing with me now. Okay. These are some of the things that we have out there, interventions that we can use to stabilize and self-regulate. They will not resolve trauma. So hear me say it loud and clear. I love these techniques. I use all of them. However, they will not resolve trauma. They're going to help you keep the lid on it, but they're not going to resolve the trauma. So great tools. Everybody I treat needs to have them. We talk about guided visual imagery. I will let them practice some. I give them lots of resources that they can use at home. We talk meditation, and there are different types of meditation. There's the focus meditation, and then there's the open mind meditation. Not everything works for everybody. So this is a big part of the trauma work, is being able to help somebody figure out what does work for them. And again, in therapy, when I open them up and they're getting distressed, I'm going to go, well, let's take a minute and meditate. Let's meditate on the safe place, and we're going to work in the guided visual imagery of the safe place. All of that should be in place before you go digging around in somebody's trauma. Mindfulness is huge right now. And I think it's a great technique that, we can use with almost any client, but specifically with our trauma clients. CBT and DBT are both amazing, really great techniques. All of these things you can be trained on while you're still a student. Yoga, I don't know. I actually had one of my students many years ago. She left and became like a yoga master. And I don't want you to leave counseling, but definitely incorporate some of the techniques in. And you can do them. I'm using some yoga techniques with my 80-year-old parents, and I got flashcards, and I just make them do stretches every day. These are some good things that you can get your clients to do that will help them stabilize and self-regulate when they get dysregulated. I'm a huge fan of the expressive therapies. I told you I'm an art therapist, so a little coloring is always a great thing. And really, I say that kind of flip, but I don't mean it that way. That bilateral movement of coloring is unbelievable in calming someone down. And if you give them a mandala, it just has to be a circle drawn on a piece of paper. I tend to draw big, dark lines, so it's a big boundary. And then I say, dump whatever you want inside that. It can be words or colors, but that motion and the container will really help someone in a crisis situation. So look for kind of expressive therapy techniques like that. I know that we're having the is it the ACC conference coming up? So that'll be a place you guys could pick up some of those things. Dr. Stretch knows all about that.
Just a little bit.
Just a little bit. So pay attention, because this is where you can get some techniques. And then a real quick mention about alpha stim, that's cranial electrostimulation. You need a license to recommend this to clients, but I have used it for about 15 years. And the thing is, it's like neurofeedback. It'll change your brain waves. It's sending a 9-volt battery current through the back of your head. You shouldn't feel it. So it's not, a painful experience. You really shouldn't feel it, but it's balancing out beta waves, which are kind of your jacked up, ready to go fight waves. They're the ones that make us irritable and angry. They're also good because they get things done. But if they're out of whack, that can be problematic. So we bring them down to an alpha state where you're kind of calm and relaxed and ready to go. And that's all alpha stim is going to do, is change those 2 waves. My throat would close up before I would public speak. And I used it for that. It was unbelievable. My mom's used it for insomnia. I've got clients who are suicidal, and to keep them in the session and focus, I just use them in the therapy session. So you could do a little investigating on your own about alpha stim. It's kind of an expensive unit, but it's pretty phenomenal. The thing is, it won't stay. You have to continue using it. Neurofeedback, you could change your brain's the way it's functioning, but with alpha stim, it's not going to last. So let's talk trauma resolution for just a minute. And like when I say resolution, I mean you no longer meet the criteria because you don't have symptoms. That's resolution. That's what I'm talking about. And if you don't meet the criteria for the disorder anymore, what would you call that? You just go ahead. I don't say it like, I say it in a whisper when I go cure, because, we don't ever want to say that in our field, that you could cure anything. But if you no longer meet the symptoms or the criteria for a disorder, I don't know what else you'd call it. So there are some of us in the trauma world that are saying probably we should take PTSD out of the DSM because it can be cured. Anyway, that's a whole other training. So EMDR, you may have heard of, eye movement desensitization and reprocessing. That is like the #1 tool in my mind. And I think just across the board, most of us would say that it is the most empirically researched trauma treatment. And I have had unbelievable results with it. It doesn't work with everybody. It doesn't work really well with our dissociative clients, although you can use some of the techniques. So if they have dissociative identity disorder, I would not do EMDR with them. But other types of trauma-related problems can be resolved, straight up resolved with it. I love EMDR. I've been using it for, 22 years maybe. And I was trained, this is my 1 minute of brag, is I was trained by Francine Shapiro, and she was the person who created it. So you do a little research, and then that's my brag moment. I forgot to mention that everything on the left side are techniques that I currently use, and I tend to use a combination of these techniques, but they're all ones I use. Everything on the right, I know, but I refer out to when I need one of those techniques. So neuro and biofeedback are really great. I would prefer EMDR, but when I have a client who can't find a trigger to focus on, or I work a lot of times with weird law enforcement, what I'm going to call them, like federal marshals and, Secret Service and, unusual types of law enforcement. So they don't want to talk. And ultimately, them and combat vets and general police and fire, we train them to dissociate. Are you aware of that? Like, what a neat thing we do to our combat guys. We teach them before they go somewhere how to dissociate. The problem is, because that's a great skill to have, like I said, it's a coping mechanism. But when they come back, we don't teach you not to dissociate. So now you've got a skill that's now interfering with your family and life. But because they've been taught to dissociate, they don't come in with a trauma story. That it makes it very tricky. So if they don't have a story that they're going to talk about, it's easier for me to do neurofeedback. And I call neurofeedback no talk therapy. It's as close as I've ever gotten to no talk therapy. So they come in and I know when they're done because they tell me the trauma story, and it's not like Swiss cheese. It's a complete, non-fragmented, concise, wonderful, like not wonderful because of the trauma, but because it flows. And I know that they're done. It's amazing. We also do a test at my practice that we're reading brainwaves. So I don't know if you know neurofeedback, but when you're reading brainwaves, nothing's going into the brain. We're only reading the activity that is on the surface. Then you watch a video or a movie, whatever it is. And when you, so say we're treating anxiety, when you get anxious, the screen's going to shrink and your brain goes, wait, what? Something's wrong. And we say, okay, relax. And as you relax, the screen goes back to normal. That was a really quick snippet of how neurofeedback works. It's much more intense than that, but that's kind of how the machine is reading it and how your brain is reacting. So just like working out at a gym, we're training your brain to function at a certain peak level, which is better. And then, okay, so the test we use shows trauma, and it's unbelievable because if it's in the back of your head, it's previous trauma. But if it shows up on the top of your head, then it's current trauma. Isn't that amazing? I've had some unbelievable results with a teenager and his mom doing that. Like we were treating old trauma, but when it showed up new trauma, we questioned it. And the new trauma came out and unbelievable changed the course of treatment because we got to the real root of the problem. And that is what I feel like trauma is. I didn't mention that. I knew I'd left something out in the beginning, that I feel like it's the causal diagnosis or the root diagnosis of a lot of those DSM disorders. So if we look further and we get to the cause, sometimes it's trauma. And then if we treat the trauma, a lot of times you can resolve those symptoms that we're experiencing. All right, so some of you know about tapping. It's kind of getting a lot more attention than it had. And if you haven't heard of it, please go check it out because it's really cool. You could be trained in it right now. I do thought field therapy, which is a little more expensive and it's very precise. If you come in saying that you have a phobia, then there's a very specific formula algorithm that I'll use to treat your phobia. I went with phobia because there was a guy at a conference I was doing on phobias. And afterwards, mine was linked to a trauma. And he said, I can get rid of that phobia for you in a couple minutes. And I was like, yes, sure, I'll try anything. I wiggled my eyeballs and, I was better. So let's try the tapping. Ultimately, I had a cockroach phobia, and no joke, that was 15 years ago. I am not afraid of them at all. I will kill them. I actually caught one in a bucket and took it outside. And I was legit diagnosable phobic. So I love thought field therapy because I've seen it do unbelievable things with trauma and phobia. EFT is a little different. They are connected cousins. So EFT is emotional freedom technique. If you email me, my email is at the end, and I will give you a copy of the PowerPoint, Dr. Harris, to give them if they want it. But my contact stuff's there. I can give you the link. And you can do a self-study and teach yourself EFT. It's tapping basically on acupressure points. So instead of a needle, we just use a tap, and it's just unbelievable. Look it up. It's cool stuff. So art therapy is where I started. As an art therapist, I thought this is an unbelievable, great way for people to treat their trauma because you can put it out on the paper and you can talk about something that's a projected image. Tell me the story about the picture on the paper, and it's not personal. So that gives you distance. I will say that I use art therapy now more as a diagnostic tool so that I can see if it's trauma or if it's bipolar or whatever it is. I do have some clients, usually teenagers, who are like, they don't want to do neurofeedback and they don't want to do EMDR. So the art therapy is a great thing for them. Like I said, everything on the right side of the page, I don't do, but I can tell you that the attachment trauma and the horses, it's an unbelievable difference that they make. Brain spotting, I don't know a whole lot about, but I do know that when people are having trouble with EMDR, sometimes they'll go brain spotting and that will work. Hypnosis, similar to EMDR, but a little bit different. The somatic experience stuff, I think that is huge. I think that's going to be one of the things we see as the up and coming thing. I have a clinician at my practice who does somatic and EMDR, and she is getting unbelievable results. So if you're into polyvagal theory and any of that stuff, the somatic experiencing is really cool. I only know psychologists right now, well, mostly psychologists doing cognitive processing, and then psychiatrists have to do the medication, or a nurse practitioner. But I think if you collect a team, it's a better way to get trauma treatment done, because as I've said, it's multidimensional. It's going to affect us on all these domains. So it's really important that we are able to access the right treatment. And one treatment is not going to work for everybody, because why? We experience it very differently because of our perceptions. All right, getting ready to wrap this up. I just want to mention these. I am not an expert on this by any means. I'm going to just say that. But when I was looking a few months ago to find the research that was out there, I found this cool stuff that is basically looking at blood-based diagnosis and some treatment of trauma. Blood-based, this is cool. Like, we're now making it medical, and they can diagnose trauma based on these certain protein complexes that they find in our blood, and then they can disrupt it. Is that not really cool? Like, for a long time, Israel has had a 0% trauma rate. I don't know if they still do, but it was because they responded immediately. And this next study is a piece of what they were doing. Yeah, this is the one. So if your heart rate gets above 200 beats a minute during an event, then you are more likely to develop PTSD later. They've done a couple of studies with police officers that are showing this. And right now I have a clinician at my practice who's working with an officer. He's more in interrogation, and he's not local. I'm just going to say that. So he's in interrogation, and she has him monitoring through like a Fitbit or whatever, his heart rate. And when it gets above a certain number, I honestly don't know what the cutoff is that they've agreed on, but if it hits 120, he has to step out, and he does his mindfulness exercises until he gets it back under control, and then he can go back in. And the rationale is we're trying to avoid him escalating to the point where he triggers a PTSD episode. So there's a lot of really cool stuff going on, medical stuff that, again, I am going to say I know less about the medical stuff, but the epigenetics is huge. I think it is really important research. I just think those genetic markers, it's unbelievable what we're finding out about trauma now. So then the heart rate, there's heart rate variability studies going on. The thing I was saying about the medical and not knowing, like ketamine, I don't even know if I agree with it, but I'm not going to disagree until we find out that it's causing more problems. But, there are some therapies that we're using now, the psychedelics, with PTSD. Again, I don't know about that. I'm old, so psychedelics were not a good thing in my day. I'm just going to say I don't know. I've heard Dr. Vanderkalk speak of how controlled it is and guiding somebody through that process. Again, I don't know a lot about that, but it's definitely interesting research. And then there's the hyperbaric chambers that we're using even locally. In Norfolk, they've got some hyperbaric chambers that they're using specifically with vets who have experienced traumatic brain injuries and post-traumatic stress disorder. So there's a lot of good stuff happening in the trauma world. And now I guess we can open it up to questions, if you're still with me. It's a lot of stuff.
They're still following that. I was gathering quite a few questions myself throughout. I guess I could open it up to see if anyone wants to verbally ask a question, but if not, I have a list to go through.
I'd love to ask a question. I'm dying to know what you see in artwork of someone who has trauma versus bipolar or depression. Tell us your art history experience.
So
art therapy, I mean.
Yeah, so you guys can have me back and we can do a whole thing on this, or I'm going to try and submit it to the conference. But the short story is that when I diagnose artwork, and you really have to have a degree in art therapy in order to make a diagnosis, and I went through school with 15 women, and half of us were into this diagnostic thing and the other half used the art as a treatment modality. So we get in trouble when we start talking interpretation. So I'm just going to put that warning out there. And I don't know if you're aware, but Virginia has approved a license for art therapists now. I'm so stoked, like this is so long coming. So then it's going to make those boundaries even trickier. But when I'm diagnosing it, I'm not looking for one thing. And this is where clinicians get in trouble. They look at the image on the paper and they go, oh yeah, that's what that is. So, you know, you see something yucky like sexual abuse. Uh-oh, my lights just clicked. And then you say, oh, that's what it looks like and make the diagnosis. But that's not it. I'm looking for the pressure that they use with what media they choose, how much energy they're putting into that drawing. So let's talk clinical depression just because it's an easy one. If you think about the disorder, it says vegetative state, right? So that implies we have no energy. You will see that come out in the artwork by there's no pressure on the paper. There will be a lack of detail. So all of that can add up to, and I would want to see like 5 things before I'm going to say anything is diagnosable. So that would be one. The difference, like, let's just go there. When people are bipolar or experiencing bipolar disorder, they will have the polarities show up. So they'll have I'll say, draw your favorite weather. And they go, well, I'm a little torn. And so they'll have winter and summer. It's like, huh. And so they'll have those very distinct polarities, which don't happen with trauma necessarily. But in trauma artwork, and you guys can see this and you can just take wild guesses, but in trauma artwork, you always see, like, if they're drawing the trauma itself, not in general artwork. But if you say draw an image of that trauma, you'll see it from a bird's eye view. You'll see it from a front angle. It'll be all these different viewpoints, and it's very confusing. So it looks chaotic and messed up. So that's a big indicator it's trauma, because you're getting different views and angles. Does that sort of make sense, Marie?
It does. That's fascinating. And I absolutely will never diagnose anyone by
It's
their
pretty
artwork.
cool.
So,
It
yeah.
is pretty cool. Holes in
Yeah.
trees. You could go with that. Like, it's a problem.
They're great clues. And thank you so much for answering that.
Sure. Shannon, I think I saw your hand next, although I see Joy and Shannon hands.
Yes. Well, first, I'm blown away with what you're talking about. I'm super excited. Do you do telehealth as well? Are you seeing clients that way?
We do telehealth at my practice. COVID kind of pushed us to that. I can do EMDR telehealth. We cannot do neurofeedback telehealth. So we were still seeing people in the office as well as doing telehealth with them, kind of, as a stabilization.
Oh, okay. And my next question is, I heard you talk a lot about teenagers and their trauma. How do you approach adults, like say with the 25 or 26-year-old trauma, and now a trigger that has come, it's like opened up that whole, like, how does that work?
Great questions, Shannon. And working with adults who have had childhood trauma, it's a really interesting thing, because a lot of times you'll say, this event happened when you were a kid, and the adult brain goes, well, that wasn't so bad. That wasn't so bad, but you're viewing it as an adult. And if you get them to go back and be their 7-year-old, it's like, how did the 7-year-old experience? And it's like, oh, he was horrified. And so then that's where we've got to work from that child place rather than the adult. So part of that work with adults is getting them to link up what happened in their childhood and view it as a kid and not an adult. And then how is that being experienced in their lives? What effect has it had? Does that make sense?
No, that makes a ton of sense. And then the complex trauma, where another trauma happened after another trauma, even though it was completely different, and say it was 10 years apart, when you're impaired as that 7-year-old, now you're a 21-year-old and something happens, now you get impaired at 21. So that. Right.
And I believe, again, it's just one of my beliefs, is that one trauma, if it's not resolved, will lead to the next one because of the impairment. You're not thinking quite clearly, and you're using substances or whatever it is, it's going to lead to the next one.
Okay, I'm good. Thank you for that.
Right, Shannon, I'm looking for interns. I don't know where you are, but.
Oh, I am in Richmond. I'll come see you.
We could work out a day thing.
Okay.
All right, Joy, I saw yours next.
Hi, thank you. That was a fascinating talk. I'm curious if when you do you go straight to trauma based upon what the client is telling you, or are there assessments that you use with your clients that lead you down that path? I'm asking because I'm in an assessment course right now and I'm just curious. Thank you.
So Joy, like we do have really great assessments now. Back when I started doing this, we had no really great assessments. So the things, and I'm going to say this is the easiest assessment ever. If I hear depression, anxiety, self-esteem, and anger, if it's that combination, and sometimes I have to look, I hear a little depression and it might be low level depression, or it could be clinical. And then I hear some anxiety or I see something, and then it could be big anxiety or little anxiety. And then I ask, because self-esteem is a tricky one. You know, you would think that I have great self-esteem, but if you ask some questions, you might figure out that no, there's a ding in there. So I'll say, and I used to say it to, I say it to a lot of people, adults and kids. On a scale of 1 to 10, where 1 is the dog face girl and 1 is the homecoming queen, where do you fall? And you can get a really good gauge because, you know, if they say, oh, I'm a 2, and you're looking at someone who's an 8 or a 9, you go, oh, that's not good. Or if they say they're a 10 and you're looking at a 2, you're like, well, something's disconnected here. But, you know, that gives you an idea, and they kind of chuckle about it, you know, so it's not a threatening question. And then with the anger, you know, we don't always see that. Again, you know, you think I'm just usually very nice, but then I have a trigger and it's like, boom, and it's like not good. So I ask people if they hit a 10, and do you have trouble coming down from that? And when they go, oh yeah, like, oh yeah, it's like, okay. So when I hear that 4 combination, I'm like, all right, nowadays we have great assessments that you could go find. PTSD.va.gov, the vet site has an amazing, they have a list of all, go to the provider part. They'll give you a list of all of them. They'll tell you where you can get them. If you can't get them, you know, they'll say this one's free and online, all kinds of good stuff.
Dr. Todd, I know we won't be able to get through all of them, but I know that some of the students really wanted a resolution to the colleague.
Oh, my lady.
Smell. Yes.
I totally forgot to tell you that part. So what we did was we went to a corner of the room where no one could see us, because the tapping thing does look crazy. I'm going to admit, like, you know, we're sitting there going, do this. It's like Simon Says. So we went to the corner of the room. I said, get that thought in your head. I knew it was a trauma, so I followed the trauma protocol. We might have had to do a couple reversals, but within 20 or 30 minutes, she was like at a 0. She had started at like a 12 on a scale of 10. She got to a 0. And then the next day when she came back, she said, every night since Katrina, I've had a 6-pack. I didn't drink last night when I went home. So that was huge. And she's like, I've never felt like it was like lifted off. It's amazing. But that was a simple thought field therapy, 20, 30-minute deal. All right. So that was the resolution. You guys are good. And if you can resolve something in that 20 minutes, it's beautiful. There's sometimes, so I'm going to give you the grief one. I had a guy who had grief, we tapped, and it was a horrible like incident. He had found his daughter who had completed suicide. I got him to where he could go do the therapy with tapping, and he went and did the grief work with another therapist, which is appropriate. But it got him to a place where he could eat and function enough to go to therapy. Cool stuff.
Are there any organizations that you recommend? I know there were some specifically asking about tapping, but in general, like if they wanted more information about being trauma informed and, you know, wanted to make sure that they had everything they need, what is like your go-to resource or organization?
So SAMHSA is really the trauma informed folks, and you can find all kinds. They've got, you know, books and articles and all kinds of things. So I would say just for the information, they would be good. They can also link you up with the TF, the Trauma Focused CBT. And I think it's about $30 now. It used to be free. You might be able to find it free still, but $30, I would say it's well worth it. And that will give you the trauma informed stuff. Great sites that I mentioned throughout the presentation. So if you get it, the National Child, I always mess up all their letters. It's the long name, the National Child Traumatic Stress Network, I think is it. but they've got a lot of tools and resources and trainings that you can do. FEMA actually has some of the crisis trainings that you can do. So depending on what avenue you want to go down, I will say if you want certification, that the Association of Traumatic Stress Specialists is probably the most valid, because they really do vet people, and you've got to take a certain number of trainings in order to get that. They want 190 hours, but with a master's degree. So when you graduate, that master's degree will write off 90 of the 180. So then you just need 180 hours of additional training, and some of that can be free. And if you're on that path, I really don't mind helping you. If you want to head down that road, I will send you things so that you can get those credentials, letters after your name.
Thank you, Doc. I think I can squeeze in one more question. For those students that are interested in learning more about art therapy, is there any kind of resources or direction that you could suggest for them right now?
So I'm going to say, is it ACC, Dr. Stretch? Sometimes I get all goofy.
Yes,
with my
it's
acronym.
Association for Creativity and Counseling.
So I'm going to say their conference is going to be a great place to start. You can look up Kathy Malachiotti, does a whole lot of online kind of trauma and art therapy training.
We're actually trying to maybe get her for our keynote.
Ooh, that would be so good. And you know, she just did Kentucky, so I think you could.
Yeah.
She was bored staying at home. I think you can work this out. So those are some, you know, like thoughts. Kathy Malachiotti, Google it, you know, and see, and you'll know if they're not legit. The other one I really love is Lucia Cappuccioni. If you only remember Lucia, Lucia, Cappuccioni, put in Lucia C, and you'll get her website. But she's got great books that are journals. And I tell all the counselors, this is a great springboard, because you can use her techniques with clients. It'll give you everything you need to say to them. Don't interpret it, but use that as a discussion point, and your clients can tell you all about it. So Lucia's journals are phenomenal. And she's got them for all kinds of things, sickness and health. And it's a well-being journal and the child journal. They start to repeat a little bit of parenting journal. They're good though, good resource. Great questions.
All right, Dr. Stretch, are you gonna wrap it all up?
I'll close up. So Dr. Todd, thank you. And Dr. Harris, thank you as well. Thank you so much for a wonderful presentation. I know many of our students across all 3 concentrations are interested in trauma, and we all know that that is something that walks through your door, whether you've been or specialize in trauma or not. And so I think it's an important one to have additional training on. If any of you had questions that were just burning and you didn't get a chance to ask those, send those to Dr. Harris. She'll put those together, and we'll see if Dr. Todd will be gracious enough to respond to a few more that way. We will be posting the recording of this keynote in your residency class and also in the program office, so other students will have access to it. Tomorrow morning, we start at 10 a.m. Eastern, and we will start in my room, which starts with 312. So we will be starting here. We will do some gratitudes and some mindfulness to get us started for the day. And then we will jump into practicing your basic skills. Tomorrow is going to really be focused on skills and skills renewal, skills building, skill feedback. All of that is going to really be the focus of tomorrow. Thank you all for being here and having a wonderful first day. Thank you again, Dr. Todd and Dr. Harris for helping, and everybody else who's doing things in the background and making this all work. And I will see y'all tomorrow morning or tomorrow evening, depending on where you are, and have a blessed and restful space between. All right, take care.